Hey guys, it's Lieutenant Lee, and I'm finally getting around to recording this OB lecture that I presented to you guys in May. So we're going to go ahead and get started. We're going to cover two main topics. We're going to talk about childbirth. I want to just review these concepts. It's something we don't see very often. We don't talk about it very often. We don't train on it very often. So we're just going to review those things. And then our focus of this training is going to be preeclampsia, eclampsia. So let's get into it. So before we get into these different types of presentations and management, I want to discuss cephalic presentation or just normal presentation. The head is presenting first. We should see crowning when delivery is imminent. Once we recognize that, we want to just place our hand over the baby's head. We're not applying pressure. Hand over the baby's head to prevent explosive delivery. We don't want baby just flying out, okay? Once baby's head is delivered, okay, you will just gently guide the top shoulder out of the vaginal canal. Once that top shoulder is delivered, you should be able to guide baby upward to deliver the bottom, and then everything should be very smooth. And then once baby's fully delivered, we will dry, we will suction, we will stimulate, we will do our APGAR scoring, we will give baby to mom, we will encourage breastfeeding. We're going to prepare for delivery of the placenta. We will not cut the cord until the cord has stopped pulsating, okay? The clamps for your cord cut will be, the first one will be placed 7 inches from baby, and then from that first clamp, you're going to place your second 3 inches from that first one, okay? You'll obviously cut in the middle once the cord has stopped pulsating. And then we're just going to continue assessment on both of our patients. If we recognize bleeding, we can perform fundal massage. Obviously, we have blood products if those need to be considered as well. Otherwise, it should be hopefully a very smooth process. Very basic, very simple birth. In my term, this is all BLS unless you need to perform some sort of resuscitation, whether it's blood or cardiopulmonary resuscitation on either patient. So very simple. My students learn how to do this in our class. Now, getting into your abnormal birth presentations. We're going to start at the top. We have limb and we have breech. Limb is going to be obviously just the one leg or one arm of the baby's presenting. Big thing here is that this cannot be delivered pre-hospital. This does require a C-section. So once this is identified, it is very important that we load patient up and we rapidly transport so that they can perform the C-section, get baby out. There's nothing we can do for that kind of presentation pre-hospital. Breech, on the other hand, so breech, both legs of the baby's buttocks presents first. If you are encountering a patient with a breech pregnancy or breech delivery, it is important to identify, can I safely and rapidly transport this patient to the hospital, or is deliver imminent? Now, if you can safely and rapidly transport a patient, that is ideal. There are associated complications with breech delivery, and it is more ideal for the patient, the baby, to be delivered in the hospital. Now, breech can be delivered pre-hospital. Again, not ideal, but it can. If you do your assessment and you think, okay, baby's coming, we all know we can't stop delivery, assist the delivery just as you would in a cephalic presentation, okay? So both legs, baby's buttocks, gently guided out. Be prepared to suction. Be prepared to possibly resuscitate just because of the associated complications. And be prepared for nuchal cord. Otherwise, it should always be the goal to rapidly transport and deliver breech in the hospital. If you are rapidly transporting a limb or breech delivery, okay, you are going to have the mom lay on her left side and just try to get her to not push, and just rapidly transport. Monitor every 3 to 5 minutes, okay? For cord presentation, so moving down the list, cord presentation is the umbilical cord is presenting first. This can happen with or without membrane rupture. The big thing here is that we need to ensure that the cord is not being clamped by the cervix, okay? So when the cord is presenting first, baby's still inside the uterus, baby's still getting nutrients from the placenta through the cord. So if the cord is being clamped shut, baby's obviously receiving decreased nutrients, and we all know pediatrics are super sensitive to low O2 levels. So it's important that when we recognize this presentation, that we are doing what we possibly can to alleviate any decrease in perfusion. So with that, you're going to take a gloved hand. You're going to take your two fingers, your pointer and your middle, create a V, and you're going to insert and gently relieve pressure off the cord. Now, this is the only time we're actually putting anything inside the vaginal canal, okay? But it is important to ensure that the baby is still receiving adequate nutrients, okay? Otherwise, rapid transport still can't be delivered pre-hospital. Moving down to our last one, we have placental presentation. I'm also going to talk about placenta abruptio in this one as well. So placental presentation or placenta previa is where the placenta is either partially or completely covering the cervical opening. So with that, we're going to see some bleeding. That's not abnormal. Mom shouldn't be in too much pain, maybe some discomfort. This will happen later on in pregnancy, okay? Now, the other side of placental issues during delivery is placenta abruptio, where the placenta prematurely detaches from the uterus. The issue with this is there's two main ones. There is an increased risk of bleeding. The hemorrhage that you'll see in placenta abruptio is going to be very significant compared to placenta previa. Now, that does not mean that a placenta previa patient may not need blood products. You base that off of your assessment. But placenta abruptio is associated with massive hemorrhage, okay? Your other thing is that now that the placenta has prematurely detached from the uterus, you are going to see a decrease in nutrients to the baby because the placenta is no longer receiving nutrients from mom. Obviously, this increases significantly fetal mortality. So, the differentiating factor, how do you tell the difference between placenta presentation or placenta previa from placenta abruptio? Obviously, any bleeding during pregnancy is not normal and we should rapidly transport, especially once our patient is later in their pregnancy. But your differentiating sign and symptom is going to be the presence of pain. Again, placenta previa might be associated with some discomfort, maybe some mild pain, but it should not be a 10 out of 10 pain. Placenta abruptio is going to be significant pain along with that significant hemorrhage, okay? This is important because once this is identified, it should be a very rapid transport because baby needs to be taken out via C-section as soon as possible in hopes that the baby will be safely delivered. So that's your overview of our birth presentations and your management for each of them. We'll move on. So preeclampsia used to be known as toxemia. It's typically seen late in pregnancy, but now we're seeing it as early as 20 weeks, and it can even occur up to 6 months after delivery. So experts, there's a lack of study, a lack of data on preeclampsia, eclampsia. There's still a lot of questions. There's still a lot of it might be caused by this. It might stem from this, but at this point in time, experts believe that eclampsia stems from the placenta not working as it should, which causes a lack of blood flow to the uterus and essentially the baby. And then an increase in pressure on different organs like your kidneys and your liver and eventually your brain. When we see the decrease of blood flow to the uterus, to the placenta, typically the fetus will result in fetal growth restriction. It can cause premature births, and lots of complications can actually follow a pregnancy with preeclampsia. And again, all of this is kind of coming to the conclusion that this is a lack of blood flow to the placenta. So deliveries following a pregnancy with preeclampsia and eclampsia are some learning disabilities. We might see cerebral palsy, epilepsy, some hearing and vision problems. So it causes a lot of issues. And again, there's a lack of data, lack of understanding on what actually causes it. But with the theory of it being a lack of blood flow to the placenta, these things make sense, okay? Now, you have different risk factors. Obviously, a pre-existing history of hypertension is not ideal. and increases the risk of preeclampsia. Any pregnancy with multiples, kidney disease, lupus, diabetes, and any women who have these risk factors, they might be instructed to take a baby aspirin daily to reduce the risk of developing preeclampsia. So if you go on scene, pregnant female, taking OB instructed her to take a baby aspirin every morning, this might be why. Anyone with risk factors are already diagnosed with preeclampsia may be on MAG or labetalol to kind of control and manage the increase in pressure. So we discussed the different organs that are affected by preeclampsia, that increase in pressure. So sudden weight gain over 1 to 2 days, your decrease in urination. Those two signs and symptoms are because of the increase in pressure on the kidneys. The kidneys are not being able to function as they should, which obviously with a decrease in urination increases weight gain, okay, very suddenly. Typically seen peripherally in the hands and feet. Sharp belly pain in the upper right side, right shoulder pain, that can be associated with the increase in pressure on the liver, okay? And then obviously your headaches, your dizziness, changes in reflexes, your visual changes, those are all associated with neurological changes, increase in pressure on the brain. And then obviously the key vital sign in these patients is going to be that high blood pressure. Okay, typically we're looking for a systolic above 160. Now this number is not hard and fast, right? If you have a patient presenting with changes in reflexes, sharp belly pain in the upper right side, and they have a systolic blood pressure of 158 and they're 7 months pregnant, we need to err on the side of caution and treat it as a preeclampsia patient because the body is telling us preeclampsia, preeclampsia, preeclampsia. This is why doing a thorough assessment is so important, okay? And then preeclampsia as a whole can lead to something called HELP syndrome. Now, it's not super common. It's not something that we talk about hardly at all pre-hospital, and it's super rare. Basically, HELP, HELLP syndrome, is hemolysis, elevated liver enzymes, low platelet count, okay? So with those things, they increase the risk of severe hemorrhage, right? The hemolysis, the low platelet count. This can only be identified in the hospital. Okay, they need blood work to identify this. We cannot diagnose this in the pre-hospital setting. But, however, we did have a HELP syndrome patient back in January, I believe. Medics made the call, arrived on scene. Patient was presenting with altered mental status and presented with low blood sugar, I believe in the 30s. Cool, easy fix, right? They provided D10 to the patient. And the patient's mental status did not change. Patient still had borderline snoring respirations and was still severely altered. So they transported. Not quite sure what was going on. Sugar after D10 was in the 200s. Should be good, right? After transport, blood work was done eventually, and it was determined that the mom was suffering from HELP syndrome. Okay, which obviously there's a lot more going on inside the body than we can identify with our assessment tools in the field. And HELP syndrome sadly is associated with high fetal mortality and even maternal mortality. Okay, in the case with our cruise, baby was born stillborn and the mom survived but barely. So just something to think about if you're making a female pregnant, presenting like a low sugar problem, but sugar's not fixing it, that should be a red flag that this could possibly be HELP syndrome. Okay, so moving on to eclampsia. Okay, eclampsia is not its own condition. It is considered a complication of preeclampsia, and it is basically established when seizures occur during pregnancy with preeclampsia. Okay, so eclampsia is rare. It only affects about 3% of people with preeclampsia, and sometimes eclampsia can occur without even signs of preeclampsia. But basically what's causing the seizures is the high blood pressure continues to build and build and build and puts pressure on the vessels in the brain, leading to those seizures, okay? So otherwise, not anything new, right? You're going to look and assess for the things we talked about in our preeclampsia slide. Just keep in mind that seizures, sudden onset, after 20 weeks of pregnancy, up to 6 months, okay, 6 months postpartum, you need to consider eclampsia, okay? Obviously, rule out your low sugar, your TBIs, things of that effect, but eclampsia should be in the back of your mind during pregnancy and 6 months after delivery, okay? So now our treatment for eclampsia, okay? For eclampsia and preeclampsia, excuse me. So for preeclampsia, once it's identified, we're going to start magnesium sulfate. We're going to do 10 mLs, which is 5 grams. We're going to put that in a 100 bag, and we're going to give it over 20 to 30 minutes, okay? You can cater and titrate this based on your patient's presentation, okay? The reason why we want to titrate this is because we want to be aware and be watching for those signs of magnesium overdose. So magnesium is a central nervous system depressant, so it relaxes and slows everything down. So with that, we see hypotension, we might see nausea, vomiting, we might see respiratory depression, bradycardia, and then obviously coma. So if that pressure is dropping too quickly, heart rate's starting to drop, we need to titrate from maybe that 20 to 25, 30, okay? We're trying to keep the blood pressure down, but we don't want to tank our patient either, okay? If you identify your magnesium overdose, we're going to give calcium. You're going to give 10 mLs over 3 minutes. According to Dr. Stevens, do 3 mLs every minute. The last minute, go ahead and give the 4, because a 3, 3, 4, that's going to be your 10. And we're only utilizing this during magnesium overdose, okay? Now, if your patient has progressed to eclampsia and they are actively seizing, okay, we are going to do 5 milligrams IV-IM-IO, okay? That is to terminate the seizure. Now, it is important that you know that the Versed dose for an eclamptic patient is going to be 5 because Versed is pregnancy category C, okay? You have 5 categories for your pregnancy meds. You have A, no risk to your patients, okay? You have pregnancy category B, which is going to be only tested in animals but no noted risk. Pregnancy category C is going to be where there is high risk in animal studies, and then pregnancy category D is where there's high risk in both animal and human studies. And then we do have our last one, which is pregnancy category X. For this one, just don't ever give it to a pregnant woman. None of our drugs that we carry are pregnancy category X, so it's not something you have to worry about at community. And I misspoke. Versed is pregnancy category D. Okay, so there's noted risk to the fetus in both animal and human studies for Versed. So we want to keep that dose low. Okay, once you've identified they're pregnant and they're seizing, go ahead and get Suit 90 en route. Okay, rather have them en route and not need them than not have them en route and need them. Okay, anything over that 5 for your pregnant patient who is seizing is going to require a supervisor and online medical control. So get them in the stretcher, get them in the ambulance, call SOUP, and go ahead, have online medical control ready to be dialed, okay? Labetalol, we can call online medical control for pregnant patients with hypertension. The big thing is that if they are still actively pregnant, still actively carrying a child, and their body is screaming preeclampsia, doc is probably going to tell you to do mag sulfate. Okay, that is your first line treatment for preeclampsia, eclampsia. Now, that doesn't mean labetalol is off the table, and labetalol could probably be very useful in your postpartum preeclampsia patients, but mag is a drug you don't need to call for, and it's your first line treatment for preeclampsia, eclampsia. Okay, and then obviously during seizures, we have hypoxia because patients stop breathing, so you want to administer high flow O2. We also want to make sure that baby's getting as much oxygen as they possibly can, because we know that, like we discussed, children are very sensitive to low O2 levels. And when your mom is seizing, baby is not getting oxygen, which means baby is probably breathing down as well. Okay, so we want to make sure we're giving high flow O2 not only for mom but for baby as well. Okay, and that's your treatment based on our protocols. Now, obviously, if there's questions on this during a call, give Doc a call. Outside of here, if there's questions, you're more than welcome to contact myself, contact Tate, ask for clarification. That's the better part about doing these lectures in person, is that we can ask questions, we can discuss these things. Otherwise, that's it for the presentation. Okay, so here's my resources. There's not, like I said, there's not a lot for preeclampsia, eclampsia, but I did some research. I got you what I found. And if there's any questions, never hesitate to reach out to me. And yeah, I hope you enjoyed the lecture, and let me know if you guys have any questions. All right, have a good day.